Here's the latest guidelines for cervical screening. From May 2017, the old recommendations have already been replaced. Women, both HPV vaccinated and unvaccinated, are recommended to undertake an HPV test every 5 years, and it is performed from 25 years of age or 2 years after first having sexual intercourse, or whichever is later. Take note, later, not earlier. And this is done until they reach 70 to 74 years of age. For us to easily remember this, just think of HPV, where you see the somewhat hidden Roman numerals. The 2 I's is for number 2 and V is for 5. This comes handy as HPV is again done every 5 years from 25 years old or 2 years after first coitus. Now, before we get saturated with the rest of the video, let's dive into the algorithm for the management of patients according to their cervical screening test results. Notice that this is the clinician-collected specimen pathway. You could also brush through the other algorithm if the specimen is collected by the patient herself. If the results reveal that it has not detected HPV, then rescreening is done every 5 years. Notice the legend per risk. This type of patients is considered low risk. If, however, the results are unsatisfactory, then we would have to repeat HPV in 6 to 12 weeks. Note, it is 12 weeks, not months. As you know, the most important risk factor for cervical screening is HPV infection. The HPV types or strains that are most frequently associated with the cervical cancer are HPV-16 and HPV-18. If HPV is positive, note the strains detected. If oncogenic HPV type 16 or 18 is detected, refer the patient for colposcopy, regardless of the result of the liquid-based cytology. Notice that it's colored red, meaning these patients are obviously of high risk. That's pretty straightforward, but here comes the challenging part. Those patients who are of intermediate risk. If other oncogenic HPV types other than 16 or 18 are detected, if you obtain an unsatisfactory LBC, retest for liquid-based cytology in 6 to 12 weeks is done. Note, it is only the cytology that is retested. If a possible or definite high-grade squamous intraepithelial lesion or HSIL or any suspected glandular abnormality is found, that patient should be referred for colposcopy, as they are of higher risk. If negative cytology or possible low-grade intraepithelial lesion or LSIL is detected, repeat test for HPV in 12 months. So note the difference for retesting for unsatisfactory result and when the result is negative or possible LSIL or LSIL. That's repeat LBC in 6 to 12 weeks and repeat HPV test in 12 months, respectively. If the repeat HPV test no longer detects oncogenic HPV, then rescreening is done in 5 years. If again the result is unsatisfactory, then we would have to retest again in 6 to 12 weeks. As discussed a while ago, if the HPV detected is 16 or 18, we automatically refer the patient for colposcopy. If the result is HPV that's not 16 or 18, then check for the results of the liquid-based cytology. If it's unsatisfactory, then we would have to repeat again. If it's possibly HSIL, then we should refer for colposcopy. If the LPC prediction is negative or with possible LSIL, then the patient would have to further repeat HPV test again in 12 months. Note that some groups of women may be at higher risk of harboring a high-grade abnormality and should be referred for colposcopy. These patients include those who are aged more than or equal to 50 years old, those who identify as being of Aboriginal and Torres Strait Islander origin, and or they have been overdue for screening at the time of the initial screening for more than or equal to 2 years. Following a repeat test after 12 months, if the oncogenic HPV is no longer detected, the patient can be rescreened after 5 years. If HPV is detected, then we should refer for colposcopy. Alright, so again, let's go through the pathway. If the HPV test result is not detected, then that patient is low risk. So you could do a routine screening every 5 years. If the result, however, is unsatisfactory, then you would have to repeat it after 6 to 12 weeks. If the HPV detected strain is 16 or 18, that makes the patient of high risk. Hence, we must refer the patient for colposcopy regardless of the result of the cytology. Now, if the HPV detected is neither 16 or 18, then that patient is of intermediate risk. And so we would have to proceed with a liquid-based cytology. Again, if it's unsatisfactory, we would have to repeat it after 6 to 12 weeks. If it's possible HSIL or worse, then we would have to refer the patient for colposcopy. If it's negative or possible LSIL or LSIL, then we must repeat the HPV test at 12 months. If the repeat reveals no HPV detected, then we are assured that that patient is of low risk, and so a routine 5-yearly screening can be done. If it's unsatisfactory, again, we must repeat the HPV test after 6 to 12 weeks. If it's HPV 16 or 18, we would have to proceed with colposcopy. If on repeat HPV remains to be non-16 nor 18, then we would have to do repeat cytology. If it's unsatisfactory, we repeat it after 12 weeks. If it's possible HSIL or worse, we refer for colposcopy. And if it's negative, possible LSIL or LSIL, we would have to repeat HPV test again. So basically, we can repeat the HPV test up to 2 times. So in total, that's 3 times. Lastly, a very important part of the algorithm, if on second repeat of HPV testing, you note that the patient is more than 50 years old and at sea or is already overdue for screening, then we would have to proceed with colposcopy already, as these patients are high risk. Now, all the rest of the algorithm is pretty easy to memorize. You just need to put more effort into understanding the management of patients under the intermediate risk. Now, moving on to HPV vaccination. For immunocompetent people who start the HPV vaccination course at 9 to 25 years of age, a single dose is recommended. Take note that the ideal stage for the HPV vaccination is 12 to 13 years old, but it can already be given to those who are 9 years old. Now, you wouldn't also need to think long and hard enough for the cutoffs of HPV vaccination. Again, HPV to 25 years old. People who receive their first HPV vaccine dose at more than 26 years of age are recommended to receive still 3 doses with an interval of 2 months between dose 1 and 2 and 4 months between dose 2 and 3. This is also true for patients who are immunocompromised. Now, you may have already noticed what the update is regarding HPV vaccination. According to the Australian Group on Immunization, the routine 2-dose HPV vaccine schedule provided to young people aged 12 to 13 years has become a single schedule using the same Gardasil 9 vaccine. And young people, except those who are immunocompromised, who received a single dose before 26 years of age, are now considered fully vaccinated and will no longer need further doses. So Do we need to prescribe additional doses? The answer is no. Let's try answering this question. A 22-year-old woman has a cervical screening test reported as positive for HPV non-16 and 18 types and a low-grade squamous intraepithelial lesion on reflex liquid-based cytology. What is the next course of action? A. Repeat cervical screening test in 12 months. B. Do colposcopy. C. Repeat cervical screening test in 6 weeks. D. Do pap test. Or E. Refer to oncologist. This patient is of intermediate risk, and for her, we must repeat HPV test in 12 months. The answer is letter A. Next question, true or false? Oral contraceptives decrease the risk of cervical cancer. Find out the answer by watching our next video.